organisms. That's what happens. So this is the great drawing of my colleague and my mentor, Dr. Abraham Rudolph. And here you see the superior caval blood at a saturation of 40, because the brain extracts a lot of oxygen. And an inferior vena caval saturation of about 70%. And in the normal heart, these mix so that the saturation in the right ventricle is 55. Yes, you should take a picture of this. And the saturation in the left ventricle is 65. A PO2 of 26 to 28. Okay? So then the blood goes through the ductus, through the main pulmonary trunk, and most of the blood goes back to the placenta for reoxygenation, and the saturation is 60. Okay? The same saturation goes to the lungs. The blood flow to the brain, of course, and the coronary arteries is at 65% saturation, and so you get better circulation to the brain and the heart from the normal circulation in the left ventricle. Now, what about transposition without a ventricular septal defect? The same happening occurs at atrial level. 70% in the IVC, 40% in the SVC. They mix at right atrial level, and some blood goes across into the left atrium. The saturation in the right ventricle is still 55, but the saturation in the left ventricle is a little higher, and I'll explain to you why in a moment. So now the blood that comes out the pulmonary artery is going to be at a much higher saturation. Okay? So what happens when the saturation is high like that is that it causes vasodilatation of the lung pulmonary arteries. Now this dilatation of the pulmonary arteries only begins at the last 3 months of gestation. So if you look for this early, you may not find it. Okay? But what happens is in the last trimester, the lung receptors become sensitive to oxygen, and the sense of the receptors when they're sensitive to oxygen is to cause pulmonary vasodilatation. So you can see here that the pulmonary vessels are increased in the diameter over what happens. Now the lung is already extracting all the oxygen that it needs, as it does in the normal. So that the oxygen, which is 70 here in the lungs, comes back at 70 here, and that's why the saturation here increases. So not only are the pulmonary vascular sensitive, but if more blood flow is going to the lungs, as you see in transposition, then less blood flow is going to the arterial duct. And the saturation is also a little higher. But the saturation to the brain, instead of being 65, and to the heart being 65, is only 55. Okay? Alright? Alright, so let's follow this through. So now, there's less flow across the ductus, and more flow into the lungs. Okay? Then, of course, if there's more flow into the lungs, there's more flow coming out of the lungs. So there is increased pulmonary venous blood flow, okay, at a higher saturation, and that's why the saturation is 70. So the circulation in the lung has changed on the account of the oxygen saturation in transposition. Okay? What happens with this increased amount of blood flow is that this pushes the foramen ovale to the closed position. So there's less blood shunting in this direction. So the foramen ovale doesn't grow. So the foramen gets smaller and smaller and smaller. And then this doesn't work very well, and it gets thickened. And that's why some babies with transposition are born extremely blue. Okay? Alright? So we know exactly what happens. Now, Dr. Rudolph would ask me to tell you that we understand about oxygen. And the fetal brain and the fetal circulation is very good about oxygen extraction. because oxygen extraction is not just on the basis of saturation, it's on the basis of oxygen content. Okay? So if you increase the hemoglobin in the fetus, it can compensate for the oxygen delivery by increasing its hemoglobin. Okay? But what cannot happen is the metabolites that the brain uses to make brain development occur. And that structure is exclusively glucose. So if there's less of the oxygenated and rich blood going to the brain, then also there is a problem with brain development. And we know that there is some evidence now to suggest that brain development in transposition is affected. And they don't have quite the same degree of maturity of brain development as normal babies. So that's the ductus story. Now, if the ductus is open, the ductus venosus is open, you get this high saturation coming into the left ventricle. But as Joanich had shown, if you close this, the saturation to the left side drops, the saturation to the right side increases, and to some extent this is compensated. But nobody will take a fetus now, a human fetus, and do this kind of experiment on it. So I showed you our case, and I showed you the left to right ductus shunt in utero. And the other part of this is we found there's the normal atrial septum in transposition. You can't recognize that there's transposition because we're only looking at the back part of the ventricles, and we didn't see that the exits to the ventricle are parallel in this particular picture. But I wanted to show you this with regard to the atrial septum. And here you can see the atrial septum, and it's going backwards and forwards across the foramen ovale. Why is it doing that? Because there's an increased amount of pulmonary blood flow coming back, and the foramen is a very thin structure, about as thin as an onion skin, and it can herniate across the atrial septum. So there you see the sort of mechanism that's going to set up a fetus for developing atrial septal restriction. And indeed, this was taken from one of the babies on our series that had a restricted atrial septum. Now, as Dr. Hornberger and Dr. Rudolph had shown, if you look at this, what should happen is that the ductus arteriosus might be smaller. And here you see the ductus, which should be the largest structure in the chest, is much smaller, and the foramen of it, the isthmus of the aorta, is much larger. So larger isthmus, smaller ductus, increased pulmonary blood flow into the lungs. And these two combinations seem to yield to us a reason to set up these patients and look at them. So we used, in fact, all patients with transposition that we were able to recognize in utero and follow them until after birth. And we excluded patients with moderate to large ventricular septal defects or double outlet, so that's not going to be a problem. So we reviewed all the fetuses over a 8-year period, and we examined these areas. And then I showed you what the hypermobility was all about, and we examined the PDA size, shunting patterns, okay? And our results was 15 of the 29 patients of those with those criteria required an urgent balloon atrial septostomy, and 10 had a hypermobile septum, while 14 did not, which is interesting, and 9 had a restrictive ductus arteriosus, while 13 did not need a balloon atrial septostomy. So it wasn't an absolute phenomenon, but when you combine the two, they became much more significant. So the combination of a hypermobile septum and reverse ductus shunt had an even higher sensitivity and specificity. And this actually comes out nice on your screen then online. And all of these add up to 12. And the sensitivities were fairly high for the hypermobile septum. They were very good, but not perfect for the and specificity were not good here's the positive predictor values, and this is other data which shows that they didn't really tell us. So this is a two-tailed look at these, and you can see that really with these two features, we had a look at this. Now this is a patient after birth. This is the same patient that had the left to right ductus shunt. And instead of this patient being born in our hospital, the mother elected to go up 250 miles away for us, and when the baby was born it was extremely blue, and you can see that the atrial septum in this baby is intact. So this baby is really not mixing its circulation very well and was at risk for developing brain damage and death. We did a rash kit immediately on getting the baby in there, balloon atrial septostomy, and now you can see a very large communication at atrial level, allowing mixing of the oxygen-rich blood in the postnatal left atrium to come into the right ventricle and then out to the aorta. So you can see the lack of communication at atrial septal level, and also the septum thickens in the last part of birth. So there you go, you can see everything that's necessary. So I've given you the summary of those, and our conclusions that certainly that patients like this require a special care, and what we do in our institution now is we look at these patients, and if there is a suggestion that these patients are going to be restrictive, the interventionist is on call sometimes even in the delivery room, and they do saturations immediately in the upper body, and if they're low, they get an urgent balloon atrial septostomy within a few minutes of life. Okay, so everything looked great until we saw the study, which was published just a couple of months ago by my friend John Simpson, on the usefulness of the prenatal echocardiogram with isolated transpositions to predict the need of atrial septostomy. And what they found is that they didn't think that the ductus and the pulmonary and the hypermobile septum was valuable, but they also looked at the radius. If you use small surveys, you don't get the whole answer. But there is a patient who's got a small atrial septal defect on their study, and you see to the total septal length is decreased, and here you can see this hypermobile septum as well as part of this abnormality. So I think we've learned a lot about the physiology of transposition. We've learned that why